Welcome, dear students. Today we are talking about the lens. At the end of our literature, we should know at least 4 causes of gradual diminution of vision, the clinical presentation of a patient with cataract, different types of cataract, and differentiate the types of senile cataract, construct a management plan for the cataract patient. First of all, I would like to ask this question. What are the causes of gradual diminution of vision? Mainly, the cataract is the commonest cause of gradual diminution of vision. Open-angle glaucoma, errors of refraction, and other chronic retinal disorders like retinopathy, retinitis pigmentosa, and optic atrophy. What is cataract? The cataract is opacification of the crystalline lens. We could classify it on many bases. One of the important classification is the etiological classification. According to the etiology, we may have the congenital cataract, which starts since childhood, the senile cataract, which is age-related, traumatic cataract, and complicated cataract, which is related to local ocular causes and general systemic causes. According to the age, we may have the soft cataract. The soft cataract is the cataract with soft nucleus or poorly developed nucleus. This happen to patients less than 25 years old. And above this age, above 25 years, we have a well-constructed and well-developed nucleus, so this is called hard cataract. According to the layer affected, we may have the subcapsular cataract, which either anterior or posterior subcapsular, cortical cataract, and nuclear cataract. Where is anterior subcapsular cataract? Here is a sort of posterior subcapsular cataract, which is called here posterior polar. We have the anterior cortical cataract, and here is a cortical cataract. There is a type of nuclear cataract with the grayish brown coloration of the nucleus, and this photo is for a posterior subcapsular cataract, but more diffuse than this picture. What is the senile cataract? The senile cataract is a bilateral progressive opacification of the lens affecting all the people above the age of 50 years as an age-related process. The patient is presented by gradual painless diminution of vision, progressive myopia, fixed black spots in his field. In case of cortical cataract affecting the periphery of the lens, we have an impaired night vision, impaired day vision due to nuclear cataract, unicular diplopia or plopia due to irregular refraction, colored halos around the light. In relation to the signs seen by examination of a patient with senile cataract, in case of senile nuclear cataract, we have what is called index myopia. The patient is turning to or shifting to myopic side due to increase the refractive index of the nucleus. The lens opacity in the nucleus or localized in the nucleus site, and it always takes the yellowish, brownish or black coloration due to deposition of melanin and tryptophan-derived pigment. The red reflex is impaired in case of nuclear cataract. However, in other physiological condition, which is the nuclear sclerosis, the red reflex is still maintained. However, the senile cortical cataract, the opacity mainly affects the cortex. What are the clinical stages of the senile cataract? First of all, we may have these wedges or sectors at the periphery of the lens, and this can be called incipient cataract. And as we can see, the central part of the nucleus is clear, so the vision here range between 6.6 to 6.9. This peripheral opacities may not affect the central vision. This is incipient cataract. The immature cataract is characterized by incomplete sheet of opaque lens with some clear lens fibers in between. Through these clear lens fibers, we can still see the red reflex. One of the advanced stage of immature cataract is the intumescent cataract. The intumescent cataract, there is some water droplets drawn in through the capsule inside the lens. The lens becomes swollen, as we can see, pearly white in cataract. The capsule is stretched and glistening. The anterior chamber become shallow. It could be complicated by secondary angle closure glaucoma due to block of the pupil by the swollen lens, and this type of glaucoma is called phacomorphic glaucoma. So, phacomorphic glaucoma is intumescent related glaucoma secondary to the angle closure caused by the swollen intumescent lens. It is one of ocular emergencies which require rapid removal of this lens to remove or to treat glaucoma. The mature stage, in which the lens becomes totally opaque and the vision drops to hand movement, the red reflex is completely absent. So this is sort of mature cataract. In hypermature stage, we have two types. First, the dry type, in which the lens loses the water and shrink. The capsule becomes thickened and wrinkled. The AC, or the anterior chamber, becomes so deep and the iris becomes tremulous. The escaping lens protein in the aqueous, engulfed by the macrophages, may be trapped in the trabecular meshwork and cause secondary open angle glaucoma, and this is called phacolytic glaucoma. So, phacolytic glaucoma is related mainly to hypermature cataract, and it is a secondary open angle glaucoma due to engulfing of the lens protein, engulfed lens protein by the macrophages. The wet type, or the Morganian cataract, this is called Morganian cataract. The Morganian cataract, in which the cortex become liquefied and soft, thus a nucleus by gravity sink to the bottom of the capsule, giving this picture. This is the wet type of hypermature cataract. The hypermature cataract could be complicated by phacolytic glaucoma, phacotoxic uveitis. This proteolytic substance can cause irritation of the uveal tract. Endophthalmitis, this is the inflammation of the interior of the eye. It's called endophthalmitis phacoanaphylactica. Subluxation or dislocation of the lens due to weakness, degenerative weakness of the venules. So we can conclude the stages of senile cataract into incipient, immature cataract, opacification of some of the lens fibers with some clear fibers in between, mature cataract, in which opacification of all lens fibers with no red reflex in between, and at last the hypermature cataract, in which there is secondary changes of the capsule, wrinkling of the capsule, and maybe some deposition like calcium deposition or lipid deposition on the lens capsule. So, what are the types of senile cataract? We can conclude now the types of senile cataract. Revise this table. The incipient cataract. The vision in the incipient cataract is mildly affected. The anterior chamber is normal. The iris is normal. And the lens have, you remember, the opaque wedges on the periphery of the lens with normal capsule. And I can see the red reflex clearly with these dark sectors of cataract against this the red background. However, in immature cataract, the vision starts to become more affected. The anterior chamber is normal, the iris is normal, the lens become more opaque with some clear fibers in between, the capsule is normal, and we may see some parts of red reflex. In mature cataract, the vision drop to hand motion with normal anterior chamber, normal iris, and the lens is completely opaque. The capsule is completely normal, the red reflex completely absent. However, in hypermature cataract, the vision is dropped to hand motion, the anterior chamber become deep due to the liquefaction process, the iris start to become freely movable, and this is called tremulous iris, completely opaque and shrunken lens. The capsule is thickened and may have some secondary changes, degenerative changes, like calcium deposition or lipid deposits, and the red reflex is completely absent. How can I examine a cataract patient? If you are faced in your clinic by cataractus patient, how can you construct a protocol of management of this patient? You should assess the vision carefully, and our decision always depend on the vision of the patient. We use the oblique illumination to see the grayish opacity in the lens in case of senile immature cataract. However, in case of intumescent cataract, you may notice the glistening of the capsule, the whitish pearly white color of the intumescent cataract. In case of hypermature cataract, you may see the tremulous, wrinkled capsule with secondary deposition. The red reflex is more reliable method in estimating the maturity of the cataract, as we illustrated in the table. The fundus should be examined, and this is very important. When the cataract is early, I can see the fundus by the usual examination method using the indirect ophthalmoscopy. For example, I can see the fundus, I can judge the periphery of the fundus, I can judge the optic disc, taking an idea about the state of health of the fundus in order to take a surgical decision either to remove the cataract or removal of the cataract will not gain benefit to the patient. What about dense cataract? If we have, for example, intumescent cataract or hypermature cataract, very dense cataract in which I can't examine the fundus, what can we do in this state? We can depend on the retinal function test. This give an idea, these tests give an idea about the retinal function. For example, the color vision, the light projection, the pupillary light reaction, VEP, visual evoked potential, and ultrasound of the retina. Those are investigative tests. How can I take a decision in case of cataract patient? I mainly depend on the visual acuity and if it interferes with the normal daily activity of the patient. Cataract is surgically treated. Always cataract is surgically treated. The problem or my problem is when to take a decision to operate. When the vision is affected in a way that interfere with the normal daily activity of the patient according to the lifestyle of the patient. What are the surgical techniques used for surgical extraction of cataract? First of all, we have an extracapsular cataract extraction. This is abbreviated as ECCE, extracapsular cataract extraction. This is a traditional way of removal of cataract. This depends on a large incision, and we open the anterior capsule surgically and we deliver the nucleus. In case of hard cataract or senile cataract, we deliver the nucleus. So in case of extracapsular cataract extraction, we remove the nucleus by delivery through a larger section, 6 to 8 millimeter at the cornea or at the limbus. This is the site of the section, so we deliver the nucleus. So the first method of extraction is extracapsular cataract extraction through a large incision. The second way is phacoemulsification, in which this is a micro-incision cataract using ultrasound machine in emulsifying the nucleus, and then the nucleus is aspirated, and this is done through a micro-incision cataract about 2.5 to 3 millimeter corneal or limbal incision. So we have the extracapsular, we have the phacoemulsification. In extracapsular, we deliver the nucleus. In phacoemulsification, we emulsify the nucleus and then aspirate it. Another problem we have after removal of the lens is that we have to implant an intraocular lens. Because you removed the normal cataractus lens, you should replace it by intraocular lens. Sometimes we may leave the patient aphakic in case of high myopic patient, but mainly to compensate the error after removal of cataract, we implant an IOL. Mainly we implant the IOL in the posterior chamber. This is a posterior chamber IOL. It is based, or it is inserted depending on the posterior capsule. We remove the whole lens and leave only the posterior capsule to support the intraocular lens. When the patient implant an intraocular lens, this is called pseudophakic patient. Pseudophakic patient. This means a patient with an artificial intraocular lens. What are the types of intraocular lenses? We may have posterior chamber IOL. This is inserted, supported on the remnant of the posterior capsule, or anterior chamber. This is implanted in the anterior chamber in front of the iris. We may have, according to the material, a rigid IOL. This is a rigid PMMA IOL, and this can be fixed or implanted through a large incision, or soft foldable IOL, which can be folded and implanted through a micro incision. We may have the monofocal lenses or multifocal lenses, which can give vision through distances, try to imitate the accommodation in order not to lose the normal accommodation of the lens after cataract. We may implant the lens primarily at the same session, which is commonly done today, or secondary IOL, which can be done in other session, and this is spared for the complicated cases. We mainly implant primarily at the same session. So in conclusion, what is the indication of IOL? When we implant IOLs, intraocular lenses, this follow cataract surgery to replace the removed cataractus lens, and this can be done also in refractive surgeries. The phakic IOLs to correct the high refractive errors. How can we calculate the IOL power? When you put an IOL to replace the normal lens, you should result in emetropia. How can you calculate the power of the IOL? The power of the cornea, we do it by using the ultrasound depending on the power of the cornea, the keratometric power, and the axial length of the globe. These two items are used in automatic mathematical equation to give the appropriate IOL power for each patient. Some of the complication after extracapsular cataract extraction or after phacoemulsification is the opacification of the remnant posterior capsule. This is called the posterior capsular opacification. This posterior capsular opacification may happen after lens removal, and this can be treated by YAG laser capsulotomy, using YAG laser to open this opacified capsule to regain vision. This is called also after cataract, and we will discuss later on. Another old technique is the intracapsular cataract extraction, in which the lens is removed completely within the capsule. In this case, we should do iridotomy, and I mean by iridectomy a small incision in the iris to prevent the pupillary block. In this case, we should implant an anterior chamber IOL or sclerally fixed IOL. It is rarely used now and spared to some complicated cases or some subluxated lenses. Another type of cataract, now we are done with senile cataract. Another type is the complicated cataract. This is an opacity of the lens due to local disease in the eye or a systemic disease in the body. It occurs at any age, so we may have patient less than 50 with complicated cataract, or patient more than 50 with complicated cataract. It occurs at any age. What about some local causes could be complicated by cataract? Local, we mean ocular causes. Some ocular causes which can be complicated by cataract, for example, corneal ulcer, glaucoma, iridocyclitis, chorioretinitis, retinal detachment, especially when it is long-standing, retinitis pigmentosa, degenerative myopia, intraocular tumor, and some topical medication, for example, corticosteroids. Complicated cataract also can complicate systemic disorders. For example, and the most common is diabetes. We may have the true diabetic cataract, which occur in young uncontrolled diabetic patients, or pre-senile cataract. The pre-senile cataract is appearance or occurrence of senile cataract, but in younger age, before the age of 50. So diabetic patient is liable for earlier senile cataract. We call it pre-senile cataract. Other disorders like hypoparathyroidism, galactosemia, and here is cataract in the first months of life, and it is complicated. Irradiation due to exposure to infrared, X-ray, or microwaves. Toxic cataract follows intoxication by ergot or naphthalene. Systemic drugs due to prolonged corticosteroid, and heavy ankylostoma infestation. What about the management? When the cataract construct the same plan. First of all, detect the state of vision of the patient and his lifestyle. And when you take a decision to operate, if it is soft cataract in young patient, remove it as congenital. This means you will aspirate the cataract. If it is hard, this means you may need extracapsular cataract extraction or phacoemulsification. So the decision depends on the age of the patient. What about another type, which is traumatic cataract? This could be related to blunt trauma, which may cause rosette-shaped cataract, or perforating trauma due to injury of the capsule, or trauma by intraocular foreign body. If we have iron foreign body, we may have siderotic cataract with these brownish deposits which looks like rust in the lens. or copper foreign body, which may have the form of sunflower cataract. So the iron foreign body causes siderotic cataract, and the copper foreign body causes sunflower cataract. How can we manage? Again, it is very important to decide on the vision, but the state of trauma itself needs meticulous ocular examination, as we may find other ocular complications secondary to trauma. We may find, for example, traumatic retinal detachment or open corneal wound or intraocular foreign body. In case we found intraocular foreign body, we should remove it if possible. Any wound should be sutured. Ultrasound should be done to detect if there is vitreous hemorrhage or associated retinal detachment due to trauma. So we should meticulously examine the patient to detect other complications due to trauma. If the patient, if we take the decision to remove this cataract, also the same surgical technique. If it is soft, we remove it as congenital, and if it is hard, we remove it as senile. This means by either extracapsular cataract extraction or by phacoemulsification. We should regularly follow up this patient to detect the late complication of trauma if will happen. Now we are going to discuss some terms related to the lens. For example, aphakia. What is meant by aphakia? It means absence of crystalline lens in the pupillary area. What are the causes of aphakia? It could be congenital aphakia, posterior dislocation, or surgically removed lens. What are the signs seen in the patient? First of all, the patient has dropped visual acuity, jet black pupil, tremulous iris. The iris is free to move because there is no lens support, and the anterior chamber become deep. One Purkinje-Sanson image, and we will discuss Purkinje-Sanson image later on. One Purkinje-Sanson, I will find one Purkinje-Sanson on the corneal surface. However, the Purkinje-Sanson image related to the lens surface, the anterior and posterior capsule, are absent because the lens is absent. Scar of cataract surgery, if it is surgically removed. In case of posterior dislocation, we can see the lens dislocated in the vitreous, and of course the patient is transformed into or shifted to the hypermetropic side. If the patient before aphakia is emetropic, he would be at least plus 10. His refractive power would be plus 10. Here is the Purkinje-Sanson. When we have a diffuse light in front of the eye, we have three basic Purkinje-Sanson image. One on the surface of the cornea, and the other on the anterior lens capsule, and the third on the posterior lens capsule. In case of aphakia, we lose the lens, so we have only one Purkinje-Sanson image on the surface of the cornea. How can we manage aphakia? In case of bilateral aphakia, it is easier to manage by glasses or contact lens. So, bilateral aphakia is managed by glasses or contact lens. Secondary intraocular lens implantation is more acceptable treatment. In case of unilateral aphakia, you can't use glasses. In case of unilateral aphakia, correction with glasses is impossible. This will cause anisoconia, and this means unequal retinal image, and will cause binocular diplopia. This means double vision. So it can only corrected by contact lens or intraocular lens implantation. This in case of unilateral aphakia. What are the disadvantages of a spectacle lens in case of aphakia? The magnification of image size is about 25%, as it is a high hypermetropic glass. There is a lot of spherical abrasion, chromatic abrasion, restricted visual field. Cosmetically, it is unaccepted. It is very heavy lens, and it is completely unsuitable in case of unilateral cases, as it will cause anisoconia and binocular diplopia. Another term is after cataract. This means remnant of lens matter in the pupillary area following cataract operation or following trauma, either lens fibers or more common proliferation of the remaining subcapsular epithelium, causing what is called, as we call it before, posterior capsular opacification. Like this picture here is this irregularities is posterior capsular opacification, and this red color is the red reflex. What we have done here is YAG laser capsulotomy. We open the visual axis by YAG laser to regain vision and gain a clear visual axis. What about subluxation of the lens? This means displacement of crystalline lens to one side due to tearing of portion of a suspensory ligament, which we call it zonule. What are the causes of subluxation of the lens? It may be congenital, like Marfan syndrome, congenital subluxated lens, cases of retinal detachment, or acquired due to traumatic causes, degenerative causes, for example, hypermature cataract, and metabolic causes like homocystinuria. How can the patient present it? Decreased vision due to myopic astigmatism. Here we have subluxated lenses. The lenses are deviated to one side, okay, and unicular diplopia. What are the signs? The anterior chamber is irregular. Some areas are phakic and the other are aphakic, and the edges of the lens can be seen through the pupil. What are the complications related to subluxated lens? Secondary glaucoma, dislocation of the lens. If no complication, glasses is used to correct the error of refraction. But if it is complicated, we should extract the subluxated lens and correct the aphakia as usual. So another term is dislocation of the lens, not subluxation but dislocation. This displacement of the lens from its place due to total tearing or total absence of the zonules. It is either anteriorly dislocated in the anterior chamber or posteriorly dislocated in the vitreous. The anterior dislocation here is anterior dislocated lens in the anterior chamber, but it is also cataractous lens. Okay, it is complicated, could be complicated by secondary glaucoma, iritis due to irritation of the iris, and of course corneal edema due to touch of the cornea. We should remove this lens through an incision, corneal incision. What about the posterior dislocation? In the case of posterior dislocation, the lens should drop posteriorly in the vitreous, so it gives fake signs like that of aphakia, and lens may be seen in the fundus. And it is also complicated by uveitis and secondary glaucoma, and it should be removed by through pars plana vitrectomy because it is posteriorly dislocated. Thank you for your time and good luck.